Hi class, my name's Jessica and this is my PowerPoint project on my evidence-based proposal using Tenecteplase in replacement of Alteplase in the setting of acute ischemic stroke. We're going to move on to the purpose of the EBP proposal. So every 40 seconds, someone in the United States has a stroke. Every 3 minutes and 14 seconds, someone dies of a stroke. This proposal is focusing on stroke because stroke is of the utmost importance in quick, fast management and treatment to promote less of disability long term. The focus is on acute ischemic stroke treatment, as there are two types of stroke, such as ischemic and hemorrhagic. This will focus on ischemic. Currently, the first-line treatment of acute ischemic stroke is Alteplase, or TPA, which is also a tissue plasminogen activator. New research has established Tenecteplase as the superior choice in medication treatment of acute ischemic stroke. And we'll move on to the literature review and background and significance. So the research conducted was through the Sinol, Academic Search Complete, and Google Scholar to obtain research articles. The terms used were Tenecteplase versus Alteplase and benefits, and acute ischemic stroke. 6 articles were reinforced the use of Tenecteplase over Alteplase in the setting of acute ischemic stroke. These articles were all time-stamped between the periods of 2019 and 2023. Our literature review continues, as these are the 6 articles. There are small blurbs that were pulled from our conducted research and review of the articles. So Yogendra Kumar et al. Provided a study on Tenecteplase that viewed the improvement of reperfusion post-stroke with the use of Tenecteplase over Alteplase. Chinia and Sadakathula established a systematic review that focused on identifying the safety and efficacy of the medication Tenecteplase. Warwick et al. Showed that using Tenecteplase led to multiple different things: shorter door-to-needle and door-in, door-out times, non-inferior favorable clinical outcomes upon discharge, higher rates of early recanalization than Alteplase, and reduced hospital costs. Siddharth et al. Provided a qualitative approach to identifying barriers and facilitators to incorporating Tenecteplase into practice through interviewing clinicians and obtaining their views and personal experience using the drug. Burgos and Saver present a meta-analysis of 5 randomized control trials to seek clarification on whether TNK is just as superior to Alteplase. Estrella et al. Created a retrospective multi-center cohort study that took place within hospitals in Spain over 2 years and focused on research of administering TNK and the safety and efficacy of the drug, while also incorporating multiple different dosages of the Tenecteplase to see which ones are safer over the others. And we'll move on to proposed change and intervention. So the proposed change would be to implement Tenecteplase as a first-line medication over the current treatment of Alteplase in the treatment of patients with acute ischemic stroke. Tenecteplase, or TNK, is a genetically modified form of human tissue plasminogen activator, or TPA, that has advantages over RTPA or Alteplase on 3 aspects. The first aspect is that Tenecteplase has a higher fibrin specificity that makes it possible to reduce hemorrhagic complications. The second aspect is that there is greater resistance to plasminogen activator inhibitor 1 that may possess higher efficacy in clot lysis, which is a big part in treatment of an ischemic stroke. The third aspect is that there is longer serum half-life that allows for single bolus administration. In Alteplase, there are multiple administrations over the course of many hours. And we move on to how was our study guided by the EBP model. So the EBP model we followed was the Iowa model, which has 7 steps to guide the essential outline of the EBP proposal to initiate this drug Tenecteplase into a study. Our first step was to identify the issue. Our second step was to establish a question, which was, Why is Tenecteplase not in greater use across all hospitals at this time over the use of Alteplase? Our third step was to establish a team. Our fourth step was to evaluate the research through review, which we did and received 6 articles that we evaluated prior. Our fifth step was to initiate a design of a program, which we will get into later. And our sixth step would be to implement the program. And our seventh step would be to then disseminate the results to the hospital doing the proposal to see if we can actually make a change. Our proposed project methodology would be to use the specific inclusion criteria noted on your screen. The first inclusion criteria that we included was that all patients must be over the age of 18 years old. This is because specifically 18 years old and above, they can all consent for their own treatment. The second inclusion criteria would be that all patients have to be diagnosed with an acute ischemic stroke with measured deficits on the NIHSS scale and a ruled out acute hemorrhage via a CAT scan. Our third inclusion criteria is the onset of symptoms or our last known well time of less than 3 hours. Our fourth inclusion criteria is that there must be no contraindications to having IV thrombolytics. Because there are so many contraindications, sometimes this can be difficult. And the fifth inclusion criteria is that there must be no prior stroke history. This was included due to the fact that if they had a prior stroke, there may be some residual deficits which may alter the assessments at the 1 month and the 3 month mark, which we'll get into later. The proposed project methodology continued. So our recruitment methods were to obtain consent from first-time acute ischemic stroke patients presenting to the emergency department. Our type of sampling is through criterion sampling, and our sample size is through a power analysis to include 15 participants. The setting is located in a small inner-city hospital in the Northeast within the emergency department. Our ethical considerations would be informed consent. Our outcomes would be minor disability and complications post-administration for acute ischemic stroke, also including a modified Rankin score of 0 to 1, which would then confirm the minor disability and complications. Our data collection would be documented through observation with vital signs, assessment of the NIHSS scale, and the modified Rankin scale. The modified Rankin scale would then be assessed prior and post-administration, and then again at a 1 and 3 month checkup post-discharge. The reliability and validity. So through the use of the assessment and the implementation of the study by students and actual patient data within a hospital setting would further establish a solid groundwork for the reliability and validity of this proposed project. And we move on to the significance to the field of nursing. So medications are a large part of a nursing workforce. The medication administration is a key job role within a nurse's field of work. Nurses are the primary caregivers in that their patients' outcomes and future health matters upon discharge, and the new first-line treatments are important for nurses to be knowledgeable about to ensure precise quality care, especially because as a nurse, we give all of these new medications that are being researched. So it's good to have a solid handle on them. And we move forward on to innovation. All of the research presented here points to the innovation that Tenecteplase is a better choice in treating acute ischemic stroke over the current practice of Alteplase. Due to the similar qualities in improving reperfusion, the drug also outranks Alteplase in cost, while also providing the safety and efficacy needed to take over the current place of first-line treatment. And these last 2 slides presented are the references that were used throughout this project. And this is our final slide. And I just want to say thank you to everybody for watching this video.